Good evening, everyone. Welcome to 14th session of Target Volume Delineation, and today topic is going to be on carcinoma cervix. I would like to introduce Dr. Jagdishan sir, who is currently working as additional professor in the Department of Radiation Oncology, JIPMER. He is a proud alumni of JIPMER, and he has completed his MD Radiation Oncology from prestigious Institute of AIMS. Sir has also cleared his DNB Radiation Oncology, as well as he has cleared ESMO exam and has obtained European certification in medical oncology. Now I would like to request sir to start his presentation.
Thank you, Dr. Chandani, and thank you, and very good evening to all of you, all the audience who have joined for the class today. This is going to be a two-way. I'll try to keep it as much a two-way discussion as possible, since we are going to have a live demonstration of the contouring onto the RTOG atlas provided by the NRG group. So, without much ado, we'll go ahead and start the presentation. I'm going to share the entire screen because I'll be skipping between the windows quite often. So I hope I'm quite audible. Can the team reply me whether I'm audible adequately?
Yes, sir, you are audible, sir.
Okay, thank you. So today we'll discuss, I hope you have been having a series of lectures. All the audience have been, might have been following a series of lectures on different cancers. So today we'll look at how to, what are the basic principles by which we proceed with contouring a cervical cancer for an external radiation treatment plan. So external beam radiation treatment plan. The brachytherapy part has been already covered, so I'm not going to share some overlapping zones. So we'll try to be as brief and as clear as possible for a EBRT plan. So before starting with the contouring, let us know some basics of radiology and what we need to look at the imaging scans which we take up. The common scans that are taken for cervical cancers are a CT scan, contrast-enhanced CT scan, contrast-enhanced MRI scan, and a PET CT scans. These are the three common scans that are taken. Of course, modifications of the scan like an MRI with MRS or different weightage images, diffusion weightage, attenuated, and so many other variants of MRI is also available. But predominantly, we will look at what are the common things that we need to look at when we are when you're interested in an EBRT plan for cervical cancers. So when we look at any image for that matter, CT or MRI or a PET CT, we are going to just look. We are going to look at certain basic things which include the bony anatomy of the entire pelvis. So whether it is highly skewed to one side or is it symmetric, or the muscular structures are they any anatomic abnormalities like horseshoe kidneys or a pelvic kidney that is located. So some common abnormalities which might, I mean, common in the sense, the uncommon ones, which we'll have to rule out for sure before going ahead with the full plan. So of course, we'll also look at the intestines and their wall thickness, whether they are distended or not. Are they showing any signs of distension or obstruction? And large bowels as well as the small bowels. And then coming down onto the true pelvis, we will also look at the organs in the pelvis to just have a gross look. Of course, we'll go down to look at the primary target, the cervical cancer. So, but before that, we'll be looking at the perirectal fat, the attenuation kind, whether there are any gross changes that we observe, and if there are any large masses that are easily recognizable. And then we look at the uterus, vagina, and structure. This is going to be a screening look before we start our contouring. So we just have a screen look so that we ensure everything seems to be normal. And of course, the patient would have gone through diagnostic scans as well. So such scans would have already ruled out most of what we have seen now. But this is going to be just a check scan. I mean, kind of a check screen where we ensure that there are no other findings that are missed out in any of the diagnostic scans. Sometimes there might be a time gap between the diagnostic scan and the planning treatment, or at the time scans taken at the time of planning. So such time gap can introduce newer findings or newer abnormalities, which can be very well checked up. So the other parts that we're going to check up are the ovaries, or the other bladder, other parts in the pelvis, and of course any grossly enlarged lymph nodes, which we find out in the pelvis or in the inguinal region or in the para-aortic region. Many a times staging would have clearly ruled out para-aortic nodes, but at the time of imaging, we might note down a 1 centimeter or a marginally significant, which is more than 1 centimeter node in the para-aortic or more commonly in the lower para-aortic. That might come up as a new finding. So such things can be easily noted because such things can change the treatment plan sometimes. So that's why we need to have a check scan for all these aspects. Right? So then coming down before, I've told you that we will be taking MRI scans, CT scans, or we will be using PET CT scans for planning. But the most important part of it for planning is, of course, the CT scan. So we would have to take a CT scan for the dosimetric evaluation. So that is a must. And in addition, we can go ahead with an MRI scan, and we can also have a PET CT scan. Of course, I'm talking in relation to the requirement for a planning, all the imaging that is required for planning purposes. For diagnostic purposes, of course, PET CT might be useful in metastatic evaluation, and then MRI could also be useful in noting down the stage of the disease locally. But as far as planning is concerned, we are going to use CT scan and MRI. And in most of our institutions, even in my institution, we are not using MRI in our routine contouring purposes. Since we have long waiting lists for the routine MRI scans to be taken in our common departments, radiology departments. So unless we get a dedicated MR scanner, we might not be using it until then. So what I'm going to discuss much about is, we'll discuss the MRI anatomy now, and to see what is the extension of the tumor. And then I'll not discuss the CT anatomy separately. I'll jump onto the contouring software and then try to discuss alongside what are the common findings in a CT scan for cervix. And of course, PET CT, we're not going to discuss PET CT. PET CT discussion will divert our attention to much broader areas. And more often we don't encounter PET CTs in cervix scans, so I'm not going to discuss on that. So as coming on to MRI imaging for cervical cancers. So as I told, there are lots of varieties of MRI which we could take. So, but then the most common and useful variety that is apparently found to be very useful is the T2 weighted MRI scans. So the T2 weighted MRI scans are going to display all the fat in white color, and the other tissues are going to be the darker. The liquid ones will appear white, and the solid ones will appear more dark. So these are some changes that could be seen in T2 scans. And so the delineation of cervix cancer, the mass is quite much more visible, and the edges are quite more visible in a T2 scan. So as you can see in this image, you can see the bladder. You can appreciate the bladder and the rectum behind, and this is quite a large tumor that is sitting right in the place of cervix, which means it's a cervical cancer, of course. And as if you can see very clearly, it is delineated by a dark ring. So this dark ring is called as a stromal ring. So this is nothing but the fascia that is encasing the cervical region. So which is very clear from this image that the dark ring is preserved all around. So which means the tumor has not gone out of cervix into the nearby tissues. So this is one good finding from an MRI that can rule out parametrial invasion. Of course, parametrial invasion can also be assessed from clinical examination, but early parametrial invasion are very well noticed in a T2 weighted MRI image. Some more invasions that can be recognized in MRI images are, this is quite, of course, a large tumor that has invaded into the rectum. So as you can see, the highlighted components, this is a T1 contrast and this is a T2 contrast. The T1 contrast itself shows up the disease that is going into the rectum. In a T2 contrast, the edges appear more clearer. So we can very well see the dark shadows of the tumor extending onto the lumen of the rectum. So which is suggestive of a rectal invasion. Of course, we don't necessarily need an MRI to rule out rectal invasion. So we can very well do a sigmoidoscopy or a proctozygmoidoscopy or a cystoscopy to rule out both bladder and rectal invasion. But I'm just showing you the ways in which MRI scans are going to be, how an MRI looks in such scenarios. And coming on to finding a bladder invasion. So obviously you can see the dark ring as we discussed in the first picture of an MRI. The dark ring is preserved in the upper part and quite preserved in all the other areas. Of course, this area that seems to be a little bit hazy. And in this anterior part of the mass, this is a sagittal scan. So anterior part of the cervical region, you can see some loss of that ring, so which suggests bladder invasion. And of course, we can also see there is some indentation into the bladder cavity. So that again suggests bladder invasion. So this can be confirmed. So mucosal invasion is going to upstage the disease to 4A and not mere a wall invasion. So that I hope you all are clear about that. So other images that can show the benefit of an MRI is to differentiate it from a fibroid. So as you can see here, this is a retroverted uterus. This is a sagittal scan which shows bladder here. Of course, this is also a T2 weighted image. So urine appears white and the liquids appear white here. So this is the mass and this is the uterus that is retroverted. So it has gone on to the posterior part of the body. So this posterior part of the body, there is a dark shadow in the anterior wall of the uterus, which is the fibroid. Whereas this is the tumor. So the cut section of which looks like this. So of course, typically you wouldn't expect a big mass behind the cervical mass. If there is a big mass behind anything that is dark behind a cervical mass, we would all immediately attribute it to rectum, or that's a common attribution. But then here in this case, there's no lumen obviously in this dark shadow. So this is nothing but the cut part of at this level, cut part of the uterus that is seen obviously here. So, and again, when we talked about the stromal ring, as you can see, the dark ring around the cervix is quite clean in the anterior and the lateral ones, but it is lost in this arrow, which is depicted with the dark arrow. So again, there is mild parametrial in extension of the disease from the cervix. So this is the same image. I just kept it for a contrast, which we showed in the first part of the MRI. So from this MRI images, we understand that we can identify a cervical mass and we can also identify the extension into parametrium. We were able to use an MRI to identify bladder invasion and rectal invasions. So coming on to other parts of the other structures that we see in an MRI, I'm just running through 3 or 4 scans consecutively to have an idea in the lower part of the image. So basically the cervix, which is quite round in shape, as we come down, I'm sorry, let me start again. The cervix, which you see round in shape, and posteriorly you have rectum, anteriorly we have that. As we come down inferiorly, the round shaped cervix suddenly. So this is the point where cervix continues as a vagina. So the cervix ends and vagina starts at this line. So a flat part of a flat structure in the center would indicate vagina, and these are one of the ways of identifying vagina from a cervical tissue. So again, as we come down, so we can the entire structure which was occupying the space between bladder and rectum shrinks down. So as it shrinks down, the lateral structures this lateral part is formed by the levator ani muscle, which slowly cones down and then fuses into one structure called as perineal body, and that perineal body stays anterior to the rectum. So it stays between the bladder and the rectum. So this white tissue that is surrounding the entire levator ani is the ischiorectal fossa. And ischiorectal fossa, the importance of this is mainly if a disease is very large enough, it could come out of the pelvic diaphragm onto the gluteal region, which usually involves the ischiorectal fossa. So that indicates a very large tumor and a highly advanced disease, the outcome of which will be very, very dismal. So just for, of course, we don't get to see many patients developing extension into the ischiorectal fossa. It's more common with rectal cancers than with the cervical cancer. Just to give you an idea about what we need to see in an MRI scans. So now that we have understood some idea about what are the extensions possible for a primary in MRI scans, we can also discuss about how to identify nodes. I think the principle of identifying a malignant node is the short axis diameter of a node. So if this is the node, this is the pictorial representation of the node. So this is a bean-shaped node. So the short axis diameter basically represents that part. Let me just annotate this structure just to have an idea. So this is the one. So we can have some more colors. Yeah. So this is the short axis diameter, whereas this part is going to be the long axis diameter. I hope everyone is able. So the short diameter, traditionally we say if it is more than 1 centimeter, I'm writing using a mouse, so it becomes very ugly, but just you can get the concept of it. So the short axis diameter more than 1 centimeter, we call that a significant image. So that's what we call a significant, and that's what we do in most of the nodes in different parts of the body. So the idea of contouring nodes came up from Taylor et al. Presentations. publication in 2005, where of course there were so many publications on mapping nodes using different techniques that were done and using lymphangiography, and that all those were published in 1980s and others. But then this article revealed in the context of nodal contouring. So Taylor et al. Has published this mapping of nodes, and then what messages we can take from this publication is most of the nodes that drain the cervix are located within 7 millimeter of the vessel. So the vessel which we are talking about here, of course, you can obviously see the large aorta bifurcating into common iliac. Common iliac continues to bifurcate again into external iliac and internal iliac. The external iliac comes down and then it becomes a femoral artery beneath the inguinal ligament. So right from the bifurcation up till here, the 7 millimeter encircling circumference around these vessels would encompass almost 88% of all the nodes that are going to be draining the cervical region. So if we try to target and the tissues around this vessel to the tune of 7 millimeter in diameter in radius, so we would be covering 88% of the nodes. So if we need to cover 99% of the nodes, there has to be some modifications. They have suggested some modifications at different levels. Let us discuss that as we do the contouring demonstration. So coming now that we discussed about the MRI features, how primary tumor appears, and the basic principles of identifying a node, and the requirement to, or in other words, the volume required to be targeted for a nodal involvement in a patient of CS cervix. Now that let's come on, I think I need to clear the annotation here. Let me clear it. So coming on to the target volume delineation principles, so of course, all of my discussion is going to be, has been derived from the Taylor et al. Article in 2007, which has given a general guideline of contouring nodal regions, and the Japanese Journal of Oncology, an article published by Toyota, and one from a Red Journal, and of course some information is also taken from the Embrace studies. So Embrace studies, as you know, is there are a lot of Indian patients involved in Embrace studies, so that is much more closer to, which might represent an Indian picture, which include, I mean, what I mean to say is we will have a better Indian representation in Embrace studies than in many of the other studies. So which will be much closer, and we can rely more on Embrace outcomes. So of course, I'm not going to stick to one particular protocol. We will discuss the general principles of contouring, and then to do a good contouring, we need a good simulation image, and to have a good simulation, we need to prepare the patient adequately. Of course, I think most of you would have been doing this in your hospitals. I'm just refreshing it so that we'll have a general idea, and there will be minor variations between institutions. But then when let's just stick on to the principles of all this. So how do we prepare? What are the problems with a CT scan or planning in a cervical carcinoma? The cervix is right between bladder and rectum. So both of which are going to vary in volume every day. So there is we need to find some ways of standardizing the rectum inside the pelvis during the time of external beam radiation. So that would be the best way. So how to standardize that? So one way of standardizing the bladder part is, so we have a fixed volume residue in the bladder. So easiest way is to find out using an ultrasound before the treatment fraction for the patient every day, and then see how much of volume is there. If there is less volume, you inject volume through Foley's and then you keep it stable. But that becomes more cumbersome. So we can't keep Foley's in situ for the entire duration of the treatment. Of course, we do that in some prostate cancers with urinary obstruction. But in a cervical cancer scenario, we don't recommend that. So instead, what we do, we ask the patient to empty and then bring the bladder down to its residual volume, and then ask the patient to drink half a liter of water. So of course, we ask them to drink half a liter of water half an hour before the CT scan procedure. So whatever at the standard glomerular filtration rate, we assume everyone to have a standard glomerular filtration rate, and we would expect some amount of urine to collect in the bladder. So, and we expect that to be the same for the patient every time when he comes for the treatment. So of course, this is going to be followed during the entire course of the treatment. So every time the patient comes for a treatment fraction, he's going to empty his bladder and drink half a liter, half an hour before the treatment fraction, so that we can, that's the best way to ensure, or the best possible way has the same volume throughout the procedure. Coming on to bowels, unlike bladder, we cannot ensure reproducibility in the rectums, in the rectum distensions. That's a bit of a difficult task. So what we can actually ensure is to ask the patient to empty the bowels every time before coming to treatment, and of course uh, to have some good representation, we would want to take the scan without a rectal gas, because the gas formation is again one feature which can vary a lot. But in some patients, in my own personal experience, so the gas itself seems to persist throughout the course, despite deflating the gas using a rectal tube. So we will not go into that individual variations. But the principle is, if the patient has a rectal gas dimension more than 4 centimeter, let us try to deflate it with Foley's and bring it down to less than 4 centimeter. And again, we give a good oral contrast to have a difference, to identify the small bowels, large bowels, as well as the rectum very clearly in the simulation scan. Position is going to be supine, and we are going to immobilize the patient with a 6 clamp or a 4 clamp one. 6 clamp might be very tight over the inguinal region, but it's a personal choice. So let's leave it up to the institution. So the scan is taken within 100 ml, usually 1 ml per 1 milligram per 1 ml per kg. So that's around 70 ml or 60 ml for standard patients, but we can go up to 100 ml IV contrast. To the scan of venous phase. So arterial phase might, so venous phase is better so that the retention of contrast by the tumors or by the nodes are better captured. And again, if you're going to add MRI and PET scans into this one, so preferably or most importantly, get an MRI only in the treatment position. Otherwise, what would happen if you do not get an MRI in treatment, and if you get an MRI only in diagnostic scans and then try to fuse it, you will be able to fuse it in only one part of the entire series of scans or entire region of imaging. So, so to say that if you try to fuse the GTV side, the part at the aortic bifurcation or the inferior part below the ischium may not match well. So these are the issues which we get. But definitely when you're going to use an MRI, do get a dedicated MRI in a treatment position. Again, PET CT also taken in a treatment position if you're going to use it. So of course, MRI is becoming a must for a brachytherapy planning. But as far as EBRT is concerned, it is not a, we do not depend entirely on MRI for a treatment planning. So then going ahead, once we have done imaging, let's right on the day of scan, when you're done a simulation scan, ensure that the rectum is not abnormally distended. Again, bladder is not excessively distended. All those things you can have a check. If there are, as I said, if there is more than 4 centimeter of gas in the rectum, we deflate it and redo the scan, or we call the patient after another day after a good laxative treatment in the on that particular day. All right. So then we go on to contours the standard, all the organ at risk. So contouring organ at risk may not be a difficult task, of course. So all the organs are going to be clear. I hope people would have a lot of experience. Peritoneal space or bowel, exact contouring of the bowel. So there are some differences, but it's again institutional practice. In our institution, we practice a peritoneal space contouring. So we try to contour the peritoneal spaces right from the below the diaphragm down up to the level of the fundus of uterus. So we don't go below the fundus of uterus. So and then bone marrow. Trying to contour bone marrow is very difficult if you are purely looking at bone marrow. But a surrogate marker of bone marrow could be the bones that are harboring the bone marrow. So what we do is we can take it from take the entire bone from L5 down up to the lesser trochanter, including all the pelvic bones, and then take it as a surrogate marker for the location of bone marrow. So that's what we do. Or we can go ahead with the functional scan and then take only the active marrow in the site. So that is another possibility. But then we in our institution, again, it's easier to contour the entire bones. So we go with an anatomical representation of the bone marrow. So finally, coming down to the target volume. So we'll be trying to focus on the target volumes. When we try to focus on it, we divide it into GTV, CTV, PTV, as is described in the ICRU guidelines. And then there are so many subcategories nowadays. So we can discuss all of that, but let's stick on to description of CTV in general. So GTV is obviously whatever gross nodes that you have identified from your clinical examination, from the CT scan which we have taken for simulation, from the diagnostic MRI, or from a planning MRI which we have taken, or in addition to the other PET CT uptake that you have noticed. So all this can be fused to, and then we can try to draw the GTVs from that. CTV is the one there is a lot of contention, there is a lot of controversies, and that's why we need to have consensus. And of course, there have been lots of groups that have come up with different consensus. So let us stick to if you look at the kind of people who have given consensus, we can have guidelines from RTOG group, and we can have guidelines from Japanese group. We also have guidelines from some centers in India like PGMR, where they have issued their own contouring guidelines for cervical cancer. And again, the Embrace protocol, and I think Embrace protocol, TMH is part of the Embrace with 2 protocols. So they are also actively involved in cervical cancer management and control. So instead of going into individual practices, let's pick up the best of what each of them have to offer. So I think rather than discussing much about the theory part of it, let me go and open up the software provided by the NRG, the RTOG group, and it's really available. Let's go to the image and then discuss that. I'm just shifting the window to. All right. So this is a simple, I think, application that can be downloaded from the RTOG website. I think the link I had put up in this presentation. So maybe most of you would have already used this. I'm just using it for better discussion. So let us start. So as I said before starting the job of contouring, we do a preliminary scan to check all the diagnostic parts. So this is a CT scan of a normal pelvis that has been shared, that has been downloaded from the RTOG website. So we are going to do contouring on a normal pelvis. So I try to catch up my own cases, but then there is no good software that can represent it as easy as this one. So we'll try to identify the basics, and we'll go with this. So let's start from the up, and then let us go down. Let us do a quick scan from up downwards. Of course, when we take scans, the upper part of the scan is determined by the previous staging. If the patient has had paraortic nodes, we would have to keep the upper part of a simulation scan starting from right in the mid thorax. So, and then coming down onto the mid thighs. So this would be the entire scanning region if you're going to include paraortic nodes in the treatment volume. And if there are no paraortic nodes, we can very well stop the upper border at the Ziphistern. So, okay. So this scan they have taken this is basically the anatomy of pelvic region. So we have focused only on this pelvic region. So as we come down, so the IVC and aorta, as we come down, the aorta is splitting now. Let's just have a quick look of the basic anatomy, and then we'll proceed with the individual contouring part. So aorta is bifurcating into right and left common iliac arteries. Let's follow the right common iliac artery. The right common iliac artery comes down and then again divides into internal and external iliac. So it's gonna, I think it's already divided. Yeah. So it's dividing at this point. So at this point it is divided, and then the internal iliac is going down here, and this external iliac keeps coming down. As we come down, so external iliac is renamed as femoral artery beyond the level of the head of femur. So as it goes down the femur, this becomes the femoral artery. So this is termed as femoral artery. Fine, okay. So let's go back again to the bifurcation. So let's start with the nodal contours. So when we discuss the nodal, when we discuss the initial contouring part, I said we'll discuss mainly on the CTV part. So we can divide the CTV into 3 types. We can contour the CTV of the nodes, and CTV for the primary disease, and CTV for the other parts. So CTV, let's call it a CT1. I'll stick to the naming convention which is provided by PGI. So since that's the closest one I have in an Indian representation, so we'll stick to PGI1. So CTV1, they have tried to label it for the nodal groups. So nodes, how are you going to contour? So nodes, again, the same principle given by Taylor et al. So we're going to draw a 7 millimeter ring around the vessel. So that's aorta. So we cover a 7 millimeter ring around this, and then come down, and then the same 7 millimeter extended right up to the external iliac, the lowermost part of the external iliac, which we said is at the head of femur, the uppermost part of the head of femur. So the individual modifications that might be required are, let me come down and then let's look at the internal iliac. So this is the internal iliac that is coming down, the internal iliac vessels. So the internal iliac vessels, so the 7 millimeter applies to even internal iliac. So let's do all that for both the vessels, external iliac and the internal iliac. So internal iliac ultimately fuses and then it divides down into finally into pudendal artery, and then it comes out of the pelvis. One of the divisions are pudendal arteries, right? So after we have done a 7 millimeter expansion, the modifications that are required are we connect the spaces between the external iliac and the internal iliac to cover for the obturator group of nodes. So this obturator group of nodes is going to be contoured right from the place where the external iliac and internal iliac is being bifurcated from the common iliac. So the space between these two is going to be connected. And when we talk about connection, we are going to connect. So let me just do a drawing so that we'll have a better understanding. So I'm trying to find out the area where this is getting bifurcated. So I'm going from up downwards. Okay, so this is the common iliac. Fine. So this looks like the internal iliac group of vessels. Yeah. So once you lose track, it becomes difficult to find out which is what. So that's why I have to go back up and then come down. So this at this level, yeah. Fine. So at this level, this is the let us draw another connotation. So this is the external iliac. So we're going to generate a 7 millimeter expansion around these two vessels, and then that we follow for the entire length of the vessels. So after we have done that, we are going to fuse this gap between external iliac and the internal iliac. So this is this gap which we're talking about. So this gap is obviously it has to exclude the muscles, the obturator internus on the lateral side and the pelvic structures in the medial side, any bowels or any other spaces. So this potential space which is lying is the space for the obturator nodes. So what is the lowermost part of the obturator contours? So we come down right up till the time when it is, of course, this place is also going to be drawn. So the lowermost part, of course, is going to stop at the moment external iliac disappears. So at this level, we don't continue it here. And then the obturator nodes ideally come down surrounding the internal iliac group right up to the place where we get the obturator foramen. So the obturator foramen, at the level of obturator, once the obturator foramen appears, we stop contouring at this for the obturator node. So obturator node and the internal iliac group of nodes are going to share some common volumes, of course. And this is about the nodes following the common iliac node, nodes following the external iliac, nodes following the internal iliac, and the modification that we required for this. There are some guidelines that say we need to provide a 1.5 centimeter expansion laterally on the external iliac group. Again, that is controversial because it adds only a 1% additional risk, additional chance of capturing the lymph node. So that, but then that will increase the chance of bowel doses significantly. So we are quite safer in avoiding that 1.5 centimeter lateral expansion from the external iliac than including it. And the next part of modification which we require is, let's go back up. Let's go back to the bifurcation part again, aortic bifurcation. So the bifurcation, fine. So we're going to contour the presacral group of nodes. So presacral group of nodes is taken in front of the sacrum, 1 centimeter diameter of the 1 centimeter thickness of tissues have to be taken right in front of the sacrum. Of course, we'll have to exclude the bowels if they're going to come in. But then the bowels are a temporary structure in front of the sacrum. So we will not have to cut down our volumes just because the bowel is standing, is located in front of the sacrum. So this contour is done from the aortic bifurcation down up to the level of S1, S2 junction. I'm sorry, S2, up to S2, the lower border of S2. So that will make it a presacral group of nodes. So this presacral group of nodes is, of course, commonly included in most contouring whenever a parametrium is involved. Parametrium is not involved, we can try avoid sacral nodal contours. So this is one addition to the standard 7 mm expansion of the aortic vessels, the iliac vessels. So there are some other modifications for the nodal group. So the other modification that we would require is whether to contour the inguinal group of nodes or not. The inguinal group of nodes are the ones, I'm just coming down. So they extend along the inguinal ligament. There are two group of inguinal lymph nodes. It's better located in this coronal scan. From the anterior superior iliac spine to the pubic tubercle. So the horizontal group lies in this line, whereas the vertical group lies along the femoral artery. So it will come down along the femoral artery. The lowermost part extends up to the lesser trochanter. So we would have to contour for the vertical group as well as for the horizontal group. So these are the two groups that you contour when you have to include inguinal nodes. And what are the scenarios where we would include inguinal nodes? Inguinal nodes are usually included when the lower third or lower half of vagina is involved, because that part is supposed to deliver is drained to the inguinal nodes. And most of the nodal or involvement in the inguinal group is in the medial uh, inguinal group. So the lateral inguinal group, involvement of lateral inguinal group of nodes are very, very rare or quite unusual. But then the guidelines say that we need to contour the entire inguinal region when we try to include them in our treatment protocol. So the places where we include are when obviously inguinal node is involved, or when the lower half of vagina is involved by the tumor. So these two are the scenarios where we will include inguinal nodes. I think I have covered the nodal part from the biotic bifurcation. We have discussed about the perisacral group of nodes. We discussed about nodes along the common iliac, external iliac, internal iliac, and the space between external and internal iliac we discussed. That would become the operator group of nodes. And then we also discussed about the inguinal group of nodes. The next group of nodes which we need to identify and treat are the para-aortic group of nodes. So the para-aortic group of nodes are treated when there are two ways of treating. One is for elective nodal iridia. We have large pelvic nodes. We would try to cover the para-aortic, the inferior para-aortic group of nodes. Or if there is an obvious para-aortic nodal involvement, we try to cover the entire para-aortic region. So we'll have to treat the entire para-aortic region. So that obviously starts from the lower border is at the bifurcation, upper border goes along. So here we are going to contour both the vessels again. So the expansion volumes that are suggested are around 8 millimeter for the IVC and aorta, and 1.5 centimeter expansion on the left lateral side for the aorta. For the right lateral side, it will be only 6 millimeter expansion from the inferior vena cava. So this is the volume that is suggested to include all the nodal groups involved. Of course, as we do this expansion, whenever we find a GTV or a gross node, that also has to be included into the volume. So that also is included. So this image doesn't show up the para-aortic nodal group, but I've just told you the guidelines or the reasons where we include para-aortic nodes. Fine. So now coming on to the primary side. So the primary site involves basically the cervix. So whatever visible disease that we see here, this is apparently a normal cervix. So as we discussed, when we come down, the flat structure is the vagina, and the round structure will be the cervix. And usually, or a general principle is this junction of vagina with the cervix happens right behind the pubic symphysis. That's a general rule. So as you can see here in this sagittal scan, which is quite taken in the supine position. So this is the pubic symphysis. So right behind the pubic symphysis, we expect the cervicovaginal junction. So which means this should be the place. But here it's a little bit higher up than the pubic symphysis. So, but then these are all different ways of identifying the vaginal location. When the cervix is grossly enlarged, the vagina might also be involved in it. So, what the flat structure will not be very easily visible at this level when there is a large disease. So, in fact, the flat structure will come down way down in the line. So, which means only normal vagina appears as flat, whereas much of the vagina that is included by the tumor is all pulled up. You will not be able to see a flat structure here. That's one way of finding out the disease is quite large and it has involved a lot of upper part of vagina. So contouring the primary tumor involves all visible tumor taken from the GTV, which we described before. In addition, we would have to include the remaining part of the normal cervix. In case there is some part of cervix which is uninvolved, that has to be included in the CTV. And we would also include this entire uterus right up to the fundus. There is some controversy whether to include ovaries or not, because apparently the involvement of ovaries is to the tune of around it ranges from 1 to 3% in all historical studies, which is practically very, very minimal. But since we are not adding any great harm in a patient who is postmenopausal by including ovaries, we continue to do the practice. But of course, this practice has to be revised when we are treating younger patients. Till now, we don't have any clear guideline whether to include, whether by avoiding ovaries, we would be achieving the same tumor control or not. So we don't have any answer for that. So what other structures that need to be contoured are the adnexa as per the principles we discussed, the fundus of the uterus, body of the uterus, remaining normal cervix, and then comes the parametrium. Parametrium should also be included into the CTV. So parametrium, inclusion of parametrium is also discussed as CTV3. The PGA guidelines, they have tried to call it as CTV3, and they have tried to include parametrium. So how do we define parametrium? Parametrium is the tissue that is on the sides of the cervix. Paravaginal tissue is the tissue that is at the level of vagina. So let's go on to this image. So it will be a bit better. Let's change it to single panel view and let's have a good zoom at this image. All right. So to start with, to have an understanding, let us come to the pubic symphysis level and then go behind posteriorly. So this is the pubic symphysis level. This is the bladder we see. I'm just going from anterior to posterior. So as we go down, as I said, right behind the pubic symphysis, we expect a cervicovaginal junction. All right. So apparently, I have gone down fully now, almost to the entirety. Now I have started seeing rectal spaces also. So let's come back and then stay in the middle. So this is apparently the uterus. I'm sorry. Yeah, this is the uterus, and this is where the bladder is. So this is the cervix, and this is where the vagina is. So yes, I think it may not be very clear. Let us also see the other images. Yeah, so uterus, cervix, and vagina. Flat structure is vagina. So when we take parametrium, we are going to take lying by the side of the cervix. So yeah, paravaginal tissues are going to be there by the side of the vaginal region. So how much of the lateral sides have to be included is determined by the location of the levator ani muscle. The levator ani muscle is the lateral part of all our contours. None of our contours are going to extend. None of our CT contours are going to extend beyond the levator ani. So obviously, as you can see, the levator ani comes from it forms a lateral part as well as the inferior part of our pelvic cavity. So the levator ani, as I said, comes and fuses onto the perineal body in front of the rectum over here. So all the spaces that we see, the white spaces, are practically either a paravaginal space or a parametrial space, depending on the slice which we are looking at. So let's go on to the place where we get the body and the junction of the cervix. So this is apparently the junction of the uterine body as well as the cervix. So in this coronal image, a sagittal image. So this is the body. Let me try to do a contour just to have an idea. So this is going to be the body. And this is going to, so this part is going to be the cervix. Let me draw another one. So this is going to be the cervix. And this part is going to be the vagina. So, all right, so we have drawn three structures to understand. So the uterine body, the cervical region, and the vagina. So when we talk about parametrium, all those tissues that are lateral to this region becomes parametrium. All those tissues that are lateral to the vagina, right up to the extent of the levator ani. Lateral doesn't mean going laterally right up to the bony pelvic wall. We are talking about lateral right up to the levator ani muscle. At the lower part, getting levator ani is easy, but at the parametrial region, let us see what lateral part constitutes. So paravaginal region, this is the paravaginal region. So lateral part can go up to the levator ani, and this part is the lateralmost boundary is the obturator internus muscle. So for the parametrium also, it's the obturator internus muscle that forms the lateral boundary. So parametrium is the lateral extension of parametrium goes up to the obturator internus. So we discussed about the lower border, the lateral border. Now comes the upper border. How high can we go and call it as parametrium? The parametrium is usually stopped the moment we see an uterine artery entering into the uterus. And that is not very obvious in a CT scan. So this is one place where an MRI could help us in finding out an uterine artery. Or if we have a good contrast CT scan where we can identify an uterine artery going in. But again, we only capture this scan in the venous phase. So it becomes a bit difficult for us to identify uterine artery. The other option is to go above as long as we witness the adnexa. So let us do we so do you hear me?
Yes, sir. Yes, sir. You're audible, sir.
All right. Sorry, I had a power cut in between. I'm sorry for that. I think we can continue again. All right. So we were discussing about the parametrial extension. So we discussed about the lateral extension, which is formed with the muscle. The lowermost extension, inferior extension for the paravaginal will be vaginal tissues will be the levator ani, inferior and lateral one options. So the upper part, as long as we go above, and then we witness the adnexa. So this is the place where we see the adnexa, which is the ovaries here. So as soon as we see adnexa, parametrium apparently stops. But then obviously this method will have some overlap of the broad ligament also into the contours. But then when we cannot identify uterine artery, this is the best way to stop the upper part of the parametrium. So this structure beside the uterus, right up to the lateral pelvic wall, bounded by the muscle. So all this space is going to be included in the parametrium. So this includes, so this I think concludes the CTV contours. CTV contours of the primary, CTV contours of the uterus, normal cervix, remaining parametrium and vagina. Again, involvement of vagina, whether to include normal vagina. So when vagina is involved, then we need to include the entire upper third of vagina. But then there is no clear-cut definition, which you can see in CT scan, which could be called as upper third and all that. But in general, the practice is we can give a margin of 1 to 2 centimeter around the GTV in the vaginal region, so as to cover adequately for the CTV into the vagina. And if the vagina, if the vaginal extension is up to the lower third, then we include the entire vagina into the volumes. So this is the general principle we follow. So now that I think we have covered the primary contours and the nodal contours, so we have to only generate the ITVs and PTVs. So let me close this software and come back to our presentation. So finally, coming on to the ITVs and setup margins, so which will give us a PTV. So it has been found that the fundus of the uterus moves a lot. When compared to the cervix, the fundus of the uterus is moving a lot, and inclusion of the uterine body itself is a controversial thing now. So since the relapses in the uterine bodies are very low unless direct extension of the tumor happens into the uterine body. But then since there has been no clear guideline on this, we continue to include the uterine body into the CTVs. So as long as it remains in the CTV, we need to make sure that they fall into the ITV. So the ITV they have found is 1.5 centimeter. In fact, the fundus can move up to a maximum of 4 centimeter anterior-posteriorly or superior-inferiorly. That's the problem with fundus of uterus. So, but then we cannot give a large margin like that into for the ITV. So we have the PGI article says we can deliver around 1.5 centimeter expansion around the fundus of uterus. So superior-inferior margin as well as the anterior-posterior margins of 1.5 centimeter is suggested. So, and let me go to the some more slides and then show you what we can do. Let me just go, I'll explain this again. Let me just come to this slice. Yeah, fine. So obviously the central one, the smallest circle comprises the primary tumor, and the next circle comprises the margin, CTV margin given for the primary tumor. So which is 1 centimeter all around the GTV. In addition, this is going to be the CTV for the primary tumor. The other margin that is given here is the CTV for the nodal volumes, which includes the CTV for the primary as well as the nodal volumes. So this includes all the contours which we described for the external iliacs, internal iliacs, and the space between external and internal iliacs, and then the parametrium, and then the GTVs. All those are included in the CTVs. So this CTV for this CTV, there is no requirement for an ITV because the nodes, we don't expect them to move a lot. So we give a setup margin of 1 centimeter all around. So that's the standard setup margin which we offer. So there is 1 centimeter expansion all around the nodal CTV volumes. For the GTV and the CTV derived from the GTV, we give only an internal target volume. The setup margin, the internal target volume of 1.5 centimeters is created around the GTV. So from the GTV, as you see, 1 centimeter of CTV and another 5 centimeter of IT, total of 1.5 centimeter that is comprised for the ITV margin. So this ITV margin of 1.5 centimeter is given only at the levels of the GTV. It is not given at other levels. So that is why you can see a projection, extra projection of the PTV, final PTV that is generated for this one. This is taken from, of course, it's taken from the PGA article. So we can very well refer to the article for that. So it's published, I think, in JCRT in 2013. So in addition, ideally, we are also supposed to give a setup margin, but then the volume becomes too huge. That's why in fact, there will be compromise in the bladder targets that we would achieve, and also there will be compromise in the small bowel targets that we may achieve. So that is why a total expansion of 1.5 centimeter is limited to that maximal expansion. All right, so I think we have discussed, let me come back and discuss some 2 or 3 special scenarios where we would have to change our standard contours which we described. So these 2 pictures show when to include a rectum into the volume, and exclude a rectum and include a rectum. So we exclude a rectum when there is no parametrial invasion in the disease, in the sense at least medial. So up to stage 2B, we can exclude the rectum. So moment the disease has gone beyond stage 3B, so which means the entire lateral pelvic wall, the disease has gone up till the lateral pelvic wall, there is high risk of involvement of the uterosacral ligaments. So this part is the from the uterus, the sacrum. So uterosacral ligaments. So when there is a high possibility of uterosacral ligament, we will have to include the entire ligament into the picture. So we'll have to take a sleeve down and then include. So in cases of stage 3B, we'll have to include the rectum into the entire volume. Because otherwise, the rectum will be appearing as an isolated island of OAR's tissue within the PTV volume. That's very difficult, practically difficult to reduce the doses in such a volume. So stage 3B is one area, or whenever there is direct invasion into the direct involvement of the uterosacral ligament, evidence from MRI, in that scenario also we'll have to include the rectum into the overall PTV volume. So this is one special case where you'll have to include the rectum into the overall volumes. And inclusion of bladder into the volume, should we avoid that as a out of the CTV? It's very clear that the bladders are not excluded from the CTVs as long as it is the volumes are created using the principles we described, a 1 centimeter expansion around the GTV and for an ITV of 1 centimeter all around. A setup margin of 1 centimeter all around. So we are not going to reduce the CTV volume for that and avoid the bladder in this one. Fine. So this image is shown to, this is actually the contours which are drawn in our institute. Just to show you actual picture of what is happening in the institute. So as you can see, in fact, in this case, the lateral sleeves have been quite long. So we are not supposed to have such a long sleeves. As I described, 1.5 centimeter expansion on the aortic side of this posterior extension. On the IVC side, we will have to have only 6 millimeter expansion. And the PTV margin is given for the para-aortic nodes, depending on this is exclusively dependent on the institutional setup. So in our institution, we follow a 5 mm expansion for the para-aortic nodal region for the setup margin, which we give from the CTV to the PTV. Yeah, finally, when do we include para-aortic nodes? I think I've already described the situation when there is large pelvic nodes or when the para-aortic node itself is involved. When we do an elective para-aortic nodal irradiation, the upper border is kept at the renal level. We don't go beyond above the renal levels to include the para-aortic nodes. When we are doing para-aortic irradiation for direct involvement of a node, then we'll have to keep the upper border up to the mid border of D12 space, D12 vertebra. I think with this, I'll try to cut short, complete my presentation. If there are any questions, I can take them up. Thank you.
Thank you very much, sir, for the crystal clear presentation, sir, and especially the practical aspects with a hands-on experience on the contouring over the CT, which helped us a lot, and especially many practical points on the borders of the CTV. Thank you very much, sir. We'll go with the question, sir. Sir, is there any, I mean, how much constraint should we give for bone marrow as a OAR, sir?
Yeah, that's a common question that is asked, but technically speaking, we cannot save bone marrow when we are delivering 50 gray into it. But what we say is 90% volume. Let's say there are varying guidelines, but we can follow a 90% covering up to 20 gray or 40 gray. So that's quite wide. So we don't have a specific answer for it. For rectum, bone marrow conservation in rectums, they follow certain guidelines, but in our center, we don't practice that.
Thank you, sir. Sir, two questions regarding immobilization. Is it compulsory to use ORFIT in CS Cervix? And second question is there any advantage of using knee rest and foot rest for immobilization, sir?
I think these are mainly useful for the PTV volume generation. So that's why I said there has to be some institutional practice on this. But in general, if you say ORFIT, the only disadvantage of ORFIT is when they apply the ORFIT on the patient, they'll have to follow the same anatomical landmarks on which they applied. So that is one common area for mistakes that could happen. But again, keeping in without treating without an ORFIT is bound to have much more errors. It again depends on the, I would say, it depends on the technologists who follow the tattoos cleanly. So I think we should go with the ORFIT, especially a 6-clamp ORFIT that would make the abduction of the thighs quite restrictive. So that would avoid, especially when we are treating inguinals, we need to have a fixed thighs. So a 6-clamp ORFIT should be used in all patients that are planned for radiation treatment. And I think, what was the second part of the question you asked? Dr.
Yes, sir. Is there any advantage in using knee rest and foot rest for immobilization, sir?
Yeah, knee rest obviously cannot be used when you are treating inguinals, right? So that, and of course, we don't treat inguinals all the time. So when we don't use inguinal, when we don't treat inguinals, we can try to keep a knee rest. But by keeping a knee rest, we are going to create a crease. That has to be understood. So there is some crease that is going to be created. So that might have an additional skin reaction that could come up in the medial part of the thigh. But otherwise, that doesn't change much.
Yeah, thank you, sir. And ideally, how many seconds after the contrast injection should we start the simulation scan for CS Cervix, sir?
Yeah, I think one full arterial flow has to happen. So that we said we'll have to capture in the venous phase. So you give that and then you wait for some 1 or 2, probably around 40, within 45 seconds, I think there'll be a full complete circulation will have happened. So maybe up to 30 to 45 seconds, we can wait and then start the scan.
Thank you very much, sir. Regarding the next question is, sir, is there any advantage in using co-registration with MRI or PET if in a resource constraint setting where we have to choose between either MRI and PET or PET, which one to go for, sir?
Based on what we have described, MRI is not contributing much to the EBRT planning. It might help us in contouring deciding the volumes for a brachytherapy. But the addition of MRI to a standard contrast enhanced CT scan is minimal. And PET CT might offer some benefits in this scenario, especially when there is a para-aortic node. When an enlarged para-aortic node, if it doesn't show an uptake, then there is a very good negative predictive value for PET. So we can bring down the volume of irradiation. But then still, till now, PET CT is not recommended for staging as well as for inclusion in the planning purposes. There is no guideline to say that, but if you say there is no resource constraint, I would go with the PET CT and a CT combination rather than including an MRI in the picture. And MRI would be taken only for a baseline assessment of the volume that will help us in a brachytherapy part, not for the EBRT.
Yes, sir. Thanks for guiding us, sir, with respect to advantages of PET CT over MRI. So, in centers where CBCT imaging is not available during treatment, should we be strict if rectum is not properly prepared during simulation, sir?
Should we do what on rectum? I didn't get that.
I mean, like if for bowel preparation, in centers where CBCT is not available.
Yeah, when they are not available, what do we do on the rectum for the rectum? That's what you mean.
Yes, sir.
So the standard protocol, as we discussed, is you clean the bowels and then ask the patient to empty the bowels every time when they come for treatment. So, but the point is, when we take a scan, we do a laxative and try to clean the bowels, clean the rectum, and then take the scan. But subsequently, the patient can still have constipation. So either we need to put them on regular laxatives to ensure that they don't get their rectum loaded with stool or gas. So what we do in our center is we take a normal scan without any laxative, and we just ask the patient to empty the bowels and see with the first scan. If the first scan looks fine, we can continue to practice the same and asking the patient to empty the bowels before treatment. But if the first scan has got a lot of distension, then we'll have to use laxatives regularly. That's the option available if you're not going for an IGRT. And IGRT is a costly affair. So that again, theoretically speaking, IGRT could solve all these issues. But again, IGRT, we need to do an adaptive kind of a plan when we have variable rectum distension. So we can have a multiple plan ready with maximal rectum distension and minimal rectal distension, so that we can choose a plan of the day. So that is one option for choosing. When we use an IGRT.
Thank you, sir. Sir, should a superior margin of 7 mm regarding CTV lymph node contouring, should a superior margin of 7 mm be given above the aortic bifurcation, sir?
The reference to this is Taylor again. So when we talk about Taylor articles, we are talking about the expansion that is surrounding the vessel starting from the bifurcation. So it is an isometric expansion all around. That's what the article says. So I believe maybe the author Taylor himself can clarify, but based on what he has mentioned in the article is this. That's what we believe it is. It's an isometric expansion at the starting from the bifurcation, which would also mean that 7 mm above the bifurcation.
Thank you, sir. Sir, should the sacral foramina be included during contouring of presacral lymph nodes, sir?
Sacral foramina is mainly for the nerves. So are we going to catch the nodes in the sacral foramina is the question.
Yes, sir.
So the standard approach, as they have described, is to have only involve the tissues anterior to the vertebral body, not into the vertebral body. So we do not practice foraminal inclusion in our center.
Thank you, sir. Till what level should the lower border be extended up to in contouring presacral lymph node for CS cervix, sir?
S2 lower border, S1 and S2.
Yes, sir.
So
thank you, sir.
In front of S1 and S2.
Okay, sir. Okay. Sir, is how to accurately delineate ovaries in CS cervix contouring, sir? Will MRI help in this?
Yeah, MRI is only rescue for identifying ovaries. Otherwise, properly contrasted CT scan could help us along with the bowel contrast, because many times the bowels are small bowels are so close to the ovary, we may not differentiate whether it is a small bowel or an ovary. So if you are only going to limit to the CT scan, we need to have a good bowel contrast to differentiate a small bowel from the ovary. Otherwise, MRI is definitely going to help us in this. Again, inclusion of the ovary into the target volume is a controversial, is still controversial now. We don't know whether to exclude it for all limited volume cancers. Limited in the sense, not extensively involved diseases.
Thank you, sir. Thank you for helping us with it. Especially small bowel contrast will help in centers where only CT is available. Sir, and should we cut off the obturator CTV lymph node from bowel and bladder as it is variable, sir?
The idea of giving margin to the CTV node, nodes, margin to the vessels to cover for the nodes, is to identify the potential spaces. So the tissues that surround the vessels. So when a bladder or a bowel occupies that space, so that is not logical enough to remove it out of the body. So because of extra distension, bladder would have occupied a potential CTV nodal space, which would come down when the bladder shrinks. So it is not prudent to exclude bladder and rectum from the CTV nodal space.
Agreed, sir. Thank you, sir. Can you explain us again on the borders of parametrium, sir?
Borders of parametrium. Fine. Let me share the screen again. All right. Do we see the screen?
Yes, sir.
All right. So let's just catch. So to identify parametrium, we are going to start from the uppermost part of the cervix to the lowermost part of the cervix. The uppermost part of the cervix, as I described, first we need to use different sections to identify what is a cervical region, what is a uterine body region, what is a vaginal region. I said the sagittal scan is quite useful in that. So we identify the body. This is of course a normal one. So it's very easy to identify here. But if it is a large growth here, so that growth is going to extend onto the vaginal space and it might also invade into the uterine space, or it can just uplift the entire uterine body above. So in such scenarios, identifying this becomes a bit difficult, but what we can do, since we are going to include the paravaginal tissue and the parametrial tissue in most of the volumes, we can start the contours right from the adnexal region. So find the adnexa. So this is the adnexa. So as we go down, start contouring from here, from the edge of the uterus up to the lateral pelvic wall, which is the muscle. There is no muscle here. So obviously from here to here entirely. So I would contour this entire region as the parametrium region. Fine. And then we come down, keep coming down. Yeah. At this level, I'll draw, let me just give you some representative slices so as to give you an idea of what I'm doing. Parametrium. Another, let me go down another slice. So we keep coming down. If we can identify vagina, we can stop. That is the parametrial volume. So if we cannot identify vagina, we'll have to wait until we get a flat space here. So the flat space is going to be, the flat structure is going to be the vagina clearly. As I told you, when there is a large tumor which is invaded into the vagina, you won't get a flat structure. It becomes very difficult to say that. But in such scenarios, even if it was a vagina that is masquerading as a cervical region, involvement of the lateral part still needs to be contoured. So that the naming only differs, but then technically that volume also needs to be contoured. So we don't have to worry about whether to differentiate between a parametrial space or a paravaginal space in such a situation. So what I can do is I can still go ahead and then contour this lateral one. So again, here there is an operator internal, so I'm going to stop short of that. So this region. So all these are parametrial nodes and all the uterine vessels that are seen, that will be still part of the parametrium or paravaginal space. So ideally parametrium stops when vagina starts, and then paravaginal space part starts. Inclusion of paravaginal space will be done when vagina is involved. That's the only area where we're going to include paravaginal space. Otherwise, we would stop short. Any more clarification? I think this would tell us the upper border, lower border, medial border. Medial, there is no border practically. You are starting from the uterus or the cervix. Laterally, it is the muscle. So I think I've covered all the borders.
Thank you, sir. Sir, is there any role of giving extra margin from CTV to PTV? Like you had advised 1 centimeter, sir. Is there any advantage in giving extra margin supero-inferiorly, sir?
I think we have given an example from the PGI article, which they have found where they are commenting on the volumes that are required. So all this expansion from CTV to PTV primarily depends on how much of organ motion you get. So the best way is to find out using a 4D CT how much of organ motion is happening and then prescribe a volume. So if you have a 4D CT, leave about 4D execution of the treatment. You can have a 4D CT that will tell the exact excursion of the fundus of the uterus superior-inferiorly and anterior-posteriorly. And similarly, of course, that will tell us only the respiratory motion at that point of time. So, but the daily changes because of bladder and bowel distensions cannot be captured using that. So, based on the trial that have been referenced from the PGA discussion, we can say that 1.5 centimeter superior-inferior and anterior-posterior has to be given to the uterine body as well as the cervical tumor. So, when we give this, in addition to the ITV, we need to add a setup margin. So that's where the problem starts. When we add a setup margin is a daily setup error. We usually give that from 5 millimeter to 1 centimeter, depending on the institution. So when we add that, then those constraints for the bladder and the small bowels cannot be achieved. So then what they have recommended is to stop the maximal expansion of only 1.5 centimeter, which is supposed to include the ITV component as well as the SM component into it. So what we can prescribe routinely is at the level of GTV or from the level of uterus, create an anterior posterior volume of 1.5 centimeter and then superior inferior of 1.5 centimeter. That will be the final PTV margin.
Thank you, sir. Thank you, sir, on enlightening us on the practical aspects. So regarding inguinal lymph node contouring, is there any easy way to find the inferior border of the inguinal lymph nodes, where to stop the caudal border?
The caudal border is very easy, no? You don't need to worry much about that. Let me just share the screen. I'm sharing the right screen. Do you see the image here, which I shared?
Yeah. No, sir, not yet, sir.
Or you're seeing some other window properly. Let me share it again. Yeah. All right. So I think now you see that. So the image starts for the inguinal contouring. We always start as I said, there is horizontal component. I think we can discuss in this one better. There is horizontal component extending from the anterior superior iliac spine onto the pubic tubercle, and there is a vertical component extending from the origin of the femoral artery downwards. So when I think the question is about the inferior border. So the inferior border is a lesser trochanter. So this lesser trochanter is quite very obvious. It's the poking thing you see, on the medially emerging stuff, part of the bone. That is a lesser trochanter. We can stop right away there. And it's quite visible in a coronal scan or a sagittal scans. Or probably, I think coronal scan is much better. So when we go down in the axial scan, we can come down here. So this is the femur head. So this is where the femoral artery is. So this part all. So obviously the medial and lateral border is going to be the sartorius edge. This is the sartorius muscle. Medial part of sartorius edge will be the lateral part of the inguinal region. This medial, for the inguinal volume, the medial part will be right up to as much as you can come up to the bone and the muscle. The medial muscle here is adductor longus and adductor magnus. So we stop here. So the lower extent, as you can see, below the neck of the femur, as you come down, you see there is one projection. This out projection is the lesser trochanter. So at this place, we stop contouring the inguinals. This is the easiest way of identifying. I think it should be easy. This poke, if you can't identify this emerging poking structure in this axial scan, go and check it up in the coronal scan. So it's quite very obvious.
Thank you very much, sir, on showing us practically. I think that's it for the question, sir. Thank you very much, sir, for the wonderful presentation. And can we conclude the meeting, sir?
Yeah. Thank you from my side. Thank you very much. And thank you for the opportunity here.
Thank you, sir. Thanks for the participants for patiently listening. The next presentation of TVD will be on lung cancer by Shagun Mishra, sir, on next week, 26th. That is next week, Friday. 6 o'clock. Thank you, everyone from Jipmer. Thank you, sir. We'll end the meeting.